spectrum. I am privileged to get to introduce my friend and colleague, Dr. Lisa Moon. She did her training with us here at OU and then left and went to fellowship down at Texas Children's. And she's come back and she's established the pediatric adolescent gynecology program for us here in the state of Oklahoma. And she's part of several of our multidisciplinary groups on campus and provides teaching and all the other great stuff, and is an absolutely marvelous colleague. So I'm very thrilled, and is filling in for us somewhat last minute on this too. So I'm very grateful for that. So please welcome Dr. Moon.
Okay, perfect. So let's get started. Well, again, my name is Lisa Moon. I'm a pediatric and adolescent gynecologist. And so period problems is kind of my bread and butter. And today we're going to be specifically more talking about irregular menses and PCOS in teenagers, which kind of presents some unique challenges in this population. Let's see here. Okay, so you said if I go all the way over, and I click, and then I do that. Yeah, okay, perfect. I have no disclosures today. And I will be discussing a lot of different treatment options, but important to know that there's not actually any FDA approved medicines for treatment of PCOS specifically. So everything is technically off label. So because nothing is approved for it. But today, our learning objectives, we want to kind of understand the difference between normal and abnormal menses and be able to describe the diagnostic criteria for PCOS and the specific challenges for achieving that diagnosis in adolescents, discuss the impact of PCOS on our long-term health, and then discuss common treatment options for management. And so again, first, we're just going to talk about normal versus abnormal, and then we're going to move on to talking a lot about PCOS. So from a normal menstruation standpoint, in the United States, the median age of menarche is about 12 and a half, and most patients will have achieved menarche by age 15. It also, whenever we're looking at pubertal progression, typically occurs within 2 to 3 years after thelarche, and typically occurs once you've achieved Tanner stage 4 breast development. Evaluation for primary amenorrhea then is going to be indicated if they have not achieved menarche by age 15, or if they've not achieved menarche by 3 years after thelarche. So those definitions kind of help with figuring out cutoffs for when to start doing some workup. The first couple of years after menarche, it is normal to have some irregularity to the cycle within reason. And so we have this kind of range of every 21 to 45 days that can be within the normal. Bleeding should be about 7 days or less, and on average using 3 to 6 tampons per day. And so this box here, let's see if I can use my mouse so people on Zoom can see too. This box over here kind of goes through some red flags that we look for whenever we're evaluating somebody's menstrual pattern, whether or not we need to do some additional workup. Anovulatory bleeding is very common the first couple of years after menarche. However, for normal menstruation, 90% of cycles are still going to fall within that 21 to 45 day range. But by 3 years after menarche, the majority of cycles should be occurring kind of within every 21 to 35 days. So after those first 2 years, we should start seeing more regulation to the cycle. And at that 3-year mark after menarche, about half of their cycles should be ovulatory. And then by 5 years after menarche, almost all of their cycles should be ovulatory. Whenever we're talking about anovulation, kind of the common thing that everybody thinks of is more spaced out periods, right? So oligomenorrhea or amenorrhea of some sort, where they're skipping long stretches of time without a period. But it can also present with more frequent prolonged bleeding. And so sometimes we'll see patients who are like, I bleed for a month and then I'm off for 3 days and I start bleeding again, and I bleed for another, 60 days in a row, and then I'm off for a week and then I start bleeding again. And that is also indicative of anovulatory cycling. So keeping that in mind as well. And these patients can have quite a bit of heavy menstrual bleeding. In adolescents, this is actually one of the most common causes of heavy menstrual bleeding, and can even present with pretty severe anemia as well. But moving on to talk specifically about PCOS. in order to understand some of the challenges that we have for PCOS in teenagers, it helps to just kind of understand PCOS as a whole and how we diagnose it in adults kind of at baseline. But like as a general concept, PCOS is considered a spectrum of clinical disorders associated with this increased androgen production from the ovaries that's often associated with insulin resistance. So we kind of get this constellation of symptoms that patients can get, but not everybody all looks the same because it's a spectrum. It is the most common endocrinopathy in premenopausal women. So this is a very, very common disorder. In women that present with some sort of androgen excess, almost all of them are going to have PCOS. And then there's some other less common causes of androgen excess that are important to rule out during your workup, but most of them are going to be PCOS related. And symptoms typically begin from puberty and menarche. And so this is usually kind of a struggle that is throughout their reproductive years. It is not usually like a late onset where somebody's been normal for decades and then all of a sudden gets this. This is usually a pattern that we see starting right from the get-go as soon as they start having their periods. There's not really a single identifiable cause for PCOS. It's probably a combination of genetic and environmental factors. We know that in patients whose mom had PCOS, they have a 5-fold increased risk for also getting PCOS. So there's probably some genetic component. There's potentially some in utero component of kind of the difference in hormone exposure during pregnancy. There's kind of a whole combination of factors that probably lead to this. But ultimately, whenever patients are initially kind of starting to express some of their signs of PCOS, like in adolescents, we get some abnormal pulse frequency of your GnRH and your LH, which then leads to these like increased LH to FSH ratios, which kind of leads to these abnormal signaling pathways to the ovary. As well as kind of like your overexpression of some of your different enzymes that leads to production of the testosterone. As a gynecologist, it was always really confusing to me, like why insulin had anything to do with this, because I'm like, the ovaries are not anywhere near the pancreas. They're like not related, right? But there's actually a lot of effect of insulin on the ovary and some of the different cells in the ovary. So in patients with insulin resistance, as you're getting those increasing levels of insulin, they actually kind of like from a whole body standpoint starts decreasing their levels of sex hormone binding globulin, which increases your free concentration of those sex steroids, including testosterone. It also increases your secretion of LH and GnRH, which again is then stimulating directly to the ovary. And it also amplifies the effect of LH on the steroidogenesis in the ovary. And the ovary itself remains sensitive to the insulin despite your systemic resistance. So as those insulin levels are increasing, that effect is getting amplified in the ovary because it's not having the same resistance in the rest of the body. There's also been some mechanisms implicated where that elevated insulin level is leading to arrest of some of the follicular maturation, which then leads to, again, anovulation in PCOS. And these findings are found in patients regardless of their weight. So even normal weight versus obese patients, it's not strictly only in obese patients that we're finding these changes with insulin resistance. However, obesity is definitely a huge component of PCOS. It's not actually part of the diagnostic criteria at all, but it does contribute to a more severe phenotype of PCOS. And we know that with increased adiposity, we also get additional increased androgen production and menstrual dysfunction, even in the absence of patients that have PCOS. So obesity in and of itself can lead to some of these things. And so they can kind of compound each other. And that obesity, again, promotes the insulin resistance, as well as elevated conversion to potent androgens. From a long-term health risk standpoint, the kind of several different things that we think about. Me as a gynecologist, the first thing I always think about in patients who have PCOS is going to be their risk for endometrial hyperplasia. That's like basically like drilled into our heads during training is that like if we have these patients that have a longstanding history of anovulatory cycling, particularly if they are obese, they've got all of this unopposed estrogen, which leads to endometrial hyperplasia and then eventually cancer. And so obviously anything that we can do to try to help prevent precancer, cancer in the uterus is a goal of ours. We also, again, we've just been talking about insulin resistance and also leading to an increased risk of type 2 diabetes. The prevalence of diabetes is 10 times higher in women that have PCOS as opposed to women that don't. And so it's a pretty significant increased risk. We can also get metabolic syndrome, elevated blood pressure, elevated lipids, cardiovascular disease, non-alcoholic fatty liver disease, challenges related to some of the obesity as well. So like sleep apnea, infertility is a very huge component. So subfertility and infertility, and then depression, body image issues, eating disorders, because patients are really struggling with not just the obesity component, but severe acne, unwanted hair growth on their face, different things that can really lead to significant body image challenges. And so ultimately there's kind of this like pretty big cycle of, kind of starting in childhood, going through adolescence. Let me see if I can get my mouse up here. Starting in childhood, going through adolescence and having like kind of abnormal pubertal changes, and then going on into adulthood where we're starting to get all of these like kind of long-term health risks. And then as we then proceed to childbearing, then potentially passing on a lot of those different predispositions down and kind of restarting the cycle over again. So from a diagnosis standpoint, there's been a lot of kind of like challenges with figuring out how to diagnose PCOS because we don't have like a single diagnostic test. I don't have like the PCOS lab that I can just order and say, yep, you got it. And so there's been a lot of different criteria proposed and that sort of thing. And so historically, this was a syndrome initially described by Stein and Leventhal in the 30s. And kind of since then, there's been multiple different times where they've tried to like kind of come to a consensus and update the criteria to try to figure out what's the best way to diagnose people with PCOS that actually have it and not over-diagnose people that don't actually have it. So you can kind of see here, a lot of them are in kind of related, but then they have like some differences between them. The Rotterdam criteria is what a lot of people are very familiar with. And that is because kind of the most recent guidelines that have come out are all using kind of a modification of the Rotterdam criteria. So that was kind of the original, but then they've kind of like added some clarifications to it. So for example, the second most recent consensus guideline in 2012 was using the modified Rotterdam criteria with some phenotypic classifications to help clarify different research categories and that sort of thing. And so you can kind of see, our three main categories here are going to be some sort of anovulatory or ovulatory dysfunction, signs of hyperandrogenism, and then polycystic ovaries on ultrasound imaging, and meeting at least two of those three criteria. And so you can see that kind of breaks you down into a couple of different phenotypic classifications. So if you have patients who have the anovulatory cycling and the androgen excess with or without the polycystic ovarian morphology, you get kind of like your classic PCOS picture. Whereas if you have somebody with PCO morphology on ultrasound with androgen excess, but they're ovulating, then you get ovulatory PCOS. And then if you have patients with ovulatory dysfunction and PCO morphology, but they don't have the androgenic excess, then it's non-hyperandrogenic PCOS. The most recent guideline was released in 2018, the International PCOS Network. Again, endorses kind of the modified Rotterdam criteria, and also kind of reaffirmed this phenotypic classification for use, particularly for research clarification. And then also included a whole bunch of like just charts and charts of breakdown of like how to actually evaluate each one of these criteria. And so if you ever have some time and just want to like really understand like all of the little ins and outs of how they come up with a different criteria, it's a pretty good paper. It's this one at the bottom that's TEED that they released in 2018. So again, the androgen excess, the chronic ovulation dysfunction or irregular menses, and then the polycystic ovarian morphology, excluding any other causes that could lead to that. This is like a modified chart that tried to kind of take just the highlights from the like multiple pages of charts from that initial guideline to try to make it a little bit easier to digest. But you can kind of see here, they've got, where did my mouse go? Here's like some definitions of like what is going to meet that definition of irregular menstruation, what meets the definition for hyperandrogenism, both biochemical, so laboratory versus clinical, so exam findings, and then your ultrasound criteria. I'm not going to belabor this point too much because we'll go into a little bit more specifics when we're talking about adolescents. But that's just kind of a simplified chart of the guideline, if you will. Again, our androgen excess can be either clinical or biochemical. So exam findings versus laboratory findings. Kind of your most common clinical findings are going to be your hirsutism and your acne, but more rare would be like androgenic alopecia, clitoromegaly, deepening of the voice, depending on the amount of androgen excess they have. And then on your biochemical testing, free testosterone is considered to be the best, but you can also look at total testosterone in patients that have a normal free and total testosterone. Their DHEAS may still be mildly elevated, and that can also be from PCOS, although the majority of your DHEAS is also coming from your adrenal gland, and so also is helping you rule out like adrenal tumors and things like that. Some of the challenges from an exam standpoint is like, how do we objectively look at somebody and say that's too much acne or that's too much hair growth? And so there's some different scales that we have to try to more objectively say, yes, this person is clinically hirsute, as opposed to like, you look hairy, because that's kind of not a very, it's just a very subjective way of going about things. So this is, for example, Fairman-Galway scoring, and so there's some different modified Fairman-Galway scores that you can do, but this is kind of from the original paper, where it just kind of describes each of the different locations, and you give everything a scale from 0 to 4, based on how much terminal hair that you see there compared to vellus hair. But then that you get into a lot of weeds about what cutoff number to use. And so like, depending on which paper you use, there's like some suggest a cutoff of between 4 and 6, others say 8, others say depends on the ethnicity. And so you can, that's not the point of the talk today, but get into a whole bunch of different discussions about exactly what kind of cutoff numbers to use and that sort of thing as well. And then again, remember on our laboratory evaluation, we also need to be thinking about other causes. And so a lot of our lab evaluation is going to be also just working up the other potential things that could be contributing to their irregular menses or their hyperandrogenism. And so depending on their symptoms, we might be getting some of these other labs as well to work up some of the other causes. So talking a little bit about PCOS and adolescents specifically. So this is kind of where things get a little bit tricky because when we think about each of our criteria one by one, irregular menses happens in PCOS, happens in teenagers, and that can be normal. And ovulatory cycling, again, completely normal the first 2 years after menarche. Multifollicular ovarian morphologies, that polycystic appearance of the ovaries on ultrasound, actually normal the first several years after menarche. Having slightly higher androgens on testing when you do your labs, normal in adolescents. So if I compare the testosterone levels of a patient in my clinic to, a 30-year-old that's going to the REI clinic, they're like our cutoffs of what we consider to be like high is very, very different. So I have some really interesting conversations sometimes with my colleagues on the adult side because it's just normal as part of that pubertal process. This is the time when all of those numbers are peaking. And so what cutoff do we use as too high, right? And so that's some things that can be really challenging. And so we've got all of these diagnostic criteria that were designed for adults that just don't apply very well to teenagers. And so how do we actually diagnose PCOS in teenagers versus, or is it just normal? So there's some proposed clarifications and some different ways that we can kind of like get around some of the challenges here, right? So like acne, is it normal? Is it PCOS? Okay, I'm looking at a 15-year-old. How do I tell? Is this like just normal pubertal acne or is this PCOS acne? So some people say, okay, well, if it's like moderate to severe and it's not responding to topical treatments, that might be more indicative of PCOS as opposed to normal pubertal acne. Some people say like, okay, well, maybe we shouldn't be using ultrasound imaging. One of the things that they clarify in the guideline is that if we're going to be looking at polycystic ovarian morphology on ultrasound, it actually really should be on a transvaginal ultrasound. And so how many of my like 14-year-olds am I getting a transvaginal ultrasound on, right? Like none of them. And so like, okay, if I'm doing a transabdominal ultrasound, like what criteria can I use accurately, that sort of thing. And so the 2018 guideline that came out actually had a lot of specifics in there about the ins and outs for diagnosis in adolescents. And so they actually completely removed the ultrasound criteria and should not be used for the diagnosis in patients who are less than 8 years from menarche. So kind of those first 8 years after menarche, you don't use ultrasound criteria at all for diagnosis of PCOS. And so now we're left with just the two, irregular menses and hyperandrogenism. And they actually kind of gave us a really helpful little chart to say, okay, depending on where they are from menarche, what's the definition of irregular menses? And so if they are less than 1 year after menarche, where's my mouse? Here we go. Then can't really say much about it if they're irregular. If they're more than 1 year, but less than 3 years after menarche, if they are kind of outside of that 21 to 45 day window, then that would be concerning for PCOS potentially. If they're more than 3 years after menarche, then that 21 to 35 day window, or if they're more than 1 year after menarche and they have any cycle that's more than like 3 months without a period. So like kind of that really long spaces between periods. They also say down here, because I have a good number of patients with primary amenorrhea. So like they have primary amenorrhea because of their PCOS. So like, what if they haven't menstruated yet? So if they have primary amenorrhea by age 15 years, or if they're more than 3 years, after thelarche and haven't achieved menarche yet, then that also kind of like gets you into this category. So they've got a lot of clarifications there for us. Again, this is another table that kind of took a lot of the information from the 2018 guideline and tried to like synthesize the stuff that was specific to adolescents to try to help with some clarifications. I'm not going to like belabor this point, but you can see like this is like a whole bunch of points of clarification about those like 2 criteria, right? It's like this whole chart, which just kind of goes to show you how complicated this can get in trying to accurately diagnose people. And so then some people were like, well, should we even be diagnosing teenagers with PCOS if it's this hard to actually diagnose it? And so on the pro side of like, yes, we should be trying to diagnose it, is that this allows for early lifestyle interventions, right? Like we can start counseling patients about the long-term health effects and about prevention of diabetes and some of the challenges with weight, and screening regularly for some of these different like metabolic syndrome, making sure that they know about the risk for endometrial hyperplasia so they're on appropriate medication to try to help prevent that. Timely intervention for fertility. Again, from the gynecology side of things, like as a resident, when I was taking care of adult patients, the number of times that we would have patients who came into the clinic and who were like, we've been trying to get pregnant for 5 years and nobody ever told me that like PCOS would make it hard for me to get pregnant. It's like, oh, this is so frustrating. So like the more that we can counsel patients early so that we can help them and they know that they can ask for help, helps to avoid a lot of these long-term impacts. But on the downside, we don't want to be overdiagnosing people, right? We don't want to be slapping people with a label that they don't actually have. This can have a pretty significant, again, we were talking about earlier, impact on their sense of self and their body image. And so like now I'm like giving you this like long-term medical diagnosis that I'm not actually sure if you have or not. And what kind of long-term impact does that have on like your psyche, right? And there's also this theoretical concern about like, does this now mean that they have this pre-existing condition that significantly increases their risk for other long-term major medical conditions that is going to be problematic for like future health insurance, right? And so Another one of the points that came out with the 2018 guideline is that we should have this kind of category for teens where we call them at risk for PCOS, as opposed to like giving them a firm diagnosis. So I have a whole bunch of patients that are kind of in this gray zone where I'm like, I have a feeling I can't firmly diagnose you with PCOS because you don't meet the criteria, but like, I think this is where we're heading. And so I have a lot of patients that I'm saying, you are at risk for PCOS, and this may ultimately be what you have, but I can't 100% for sure say that it is that. And that allows for a lot of that early intervention and counseling and helping them to understand some of the long-term health effects without giving them the label. But if we're doing this, then we also need to have some way of kind of like following up on that later on, right? And so I counsel my patients about, I'm suspicious this is where this is going. In order to confirm the diagnosis later on down the road, once we get more than 8 years after menarche, then oftentimes we're talking about doing kind of a reevaluation, like a reworkup, redo the labs. Now we can get the ultrasound. That's going to count as part of our criteria, things like that. The really important thing to remember with this is that if they're on hormonal treatment, a lot of our lab workup is not accurate while they're on hormones. And so they need to be off of hormones for at least 3 months before we check a lot of those, like the testosterone, the LH-FSH, estradiol, all of those labs. So they need to kind of have this washout period for 3 months before we repeat the lab workup. And so just making sure they understand, like, down the road, probably going to do this reevaluation, usually once you're in kind of like in your early 20s, to try to get a better sense of the diagnosis. So briefly moving on to management. So part of the management, like we've just been talking about, is understanding those long-term health impacts and making sure that we're screening them regularly to be able to intervene early. And so we should be getting blood pressure measurements. We should be kind of monitoring their weight, with PCOS, it's easier to lose weight, harder to gain weight, right? And so making sure that patients understand that there can be weight challenges involved, cardiovascular disease risk, checking their lipids, depression screening, disordered eating screening, and then also having kind of a lower threshold for evaluating their endometrium for hyperplasia. This is going to be less common in adolescents, but as they get older, this is one of the criteria that we think about when we're like, does this person need to get some sort of endometrial biopsy to rule out hyperplasia malignancy? Diabetes risk, again, huge in these patients. And remember, diabetes risk is independent of their obesity. So patients that have PCOS, regardless of their weight, should be getting regularly screened for diabetes. Now, the obesity exacerbates that risk, but even patients who are at a normal weight are still at an increased risk for developing diabetes compared to their same counterparts that don't have PCOS. So doing some sort of routine screening for their diabetes risk. And this also includes some differences in what we do during their pregnancy as well, because they're at increased risk for like gestational diabetes during pregnancy. And so we're going to be getting some additional glucose tolerance testing during their pregnancy above normal for just like a routine pregnancy. Lifestyle modifications, huge component of PCOS treatment, right? So healthy eating and exercise are going to be first-line treatment for every single patient with PCOS. If they are obese, then even a small amount of total body weight loss can have significant clinical improvement on some of their symptoms. They can restore some of their ovulatory cycles. It can help with their fertility. And so talking to them about like actual attainable goals, right, is kind of specific that can lead to improvement in some of their symptoms. There's no specific like special diet or anything like that, right? It's just like healthy, balanced eating, because again, and especially with adolescents, and I know this is probably preaching to the choir in this room a little bit, but we have to be so careful when we're talking to teenagers about eating habits, right? And so making sure that we're encouraging those healthy eating habits, but also kind of keeping in mind the possibility for disordered eating in these patients, and encouraging their exercise as well. So again, kind of setting specific, measurable, and achievable goals, not just like lose weight, but like setting specific goals that they can actually achieve. Making sure that they have support from their family, right? and again, this is kind of even just outside of PCOS, but just any kind of lifestyle modifications in teenagers or children are so hard if you have parents that are not on board, right? And so making sure that we've got a good support system, that the family is on board, and getting everybody involved, right? Outside of all of that, then we also need to think a little bit about just kind of pharmacologic management. So there's a couple of different medications that we use for treating the different aspects of PCOS. And some of this depends on what are their symptoms that they are concerned about, right? And so for teens that are having very irregular menses, or if they're having a lot of the effects of the hyperandrogenism, so like the acne and the unwanted hair growth, the hirsutism, then hormonal therapy is going to be your first line management. Metformin can be used to treat the metabolic effects, the insulin resistance, and can be used alone or in combination with hormonal therapy. For hirsutism, your like birth control pills, something that has estrogen in it is going to be your first line. But we also got some like anti-androgen medications that we can use. And then there's several different things that we can do from a fertility aspect to help them ovulate predictably in order to achieve a pregnancy. And I think that's helpful to like talk to some patients about, because a lot of times when you're like, oh, this could potentially cause challenges with fertility, oftentimes they just immediately jump to, that means I'm going to need IVF in order to be able to get pregnant. It's actually not true. Most patients with PCOS are not going to need that. And you can see that's like the bottom option here on my list. We've got pill medications that we can use to help them to ovulate. And they're significantly cheaper than IVF cycles. So usually is pretty, actually fairly straightforward comparatively to some of the other things that we have to do. Talking a little bit about combined oral contraceptives. This is a first line treatment. It's got the combination of estrogen and progesterone, right? And they are going to help with a whole bunch of different things related to PCOS. So they can help regulate the period cycle, give them predictable bleeding. That is so important for teenagers, particularly school-age patients. They just want to know so that they don't have accidents at school, right? So like they want to know when their period is going to happen in a predictable fashion. And so this is very important to them. It also provides endometrial protection. So progesterone hormone is going to be the hormone that's very important for preventing endometrial hyperplasia malignancy down the road. And so that is a big component of the different hormonal options that we consider. It also is anti-androgenic. That estrogen kind of directly combats testosterone levels, if you will, because it increases your sex hormone binding globulin, which kind of gobbles up all of your free testosterone and helps to decrease their androgen hyperandrogenism, so they can get improvement in their acne and their hirsutism. You can also have like kind of some mild improvement in your lipid profiles. That's not really what we prescribe this for, obviously. Also provides contraception, so it's kind of a bonus, and is also appropriate for teens who are at risk for PCOS but don't have like a firm diagnosis. Again, like we were talking about earlier, none of these treatments are actually FDA approved for PCOS anyway, so but these can be appropriate for teenagers who are just having irregular menses to help regulate their cycles. These are the medications that are going to give you kind of the most bang for your buck, right? And so that's why this is one of our first line options. We say combined oral contraceptives, but realistically, we're talking about kind of a group of medications that is more than just pills. That includes the combination of the estrogen and the progesterone hormone. So we've also got some non-oral options. There is a transdermal patch that's weekly. There's actually 2 of them on the market now. And then the vaginal ring that is monthly. And no one of those methods is in particular superior to the others because they've all got the same combination of hormones. There's no particular progestin formulation that is preferred over the others. So you get to really kind of like find the one that works the best for the patient. And you don't have to like stress a whole lot about like knowing what's the best PCOS pill out there or something like that. And so you just kind of use the same guidelines that we use for all of our patients that we're prescribing these medications for. You do want to screen for contraindications to estrogen. So there are some patients that will have contraindications that we want to try to avoid using estrogen medications. These are pretty uncommon in the adolescent population, but kind of the more common ones that we see are going to be migraines with aura, and then clotting risk. And we kind of talked about already the anti-androgenic effect that they can have, but it actually has that anti-androgenic effect on multiple levels, and so they can be really effective for this. The one thing that's helpful to tell patients is that from a menstrual effect, it can take up to about 3 months to see how well it's going to work for their periods. But from a skin effect, so like treatment of their acne and hirsutism, it can take up to 6 months to see the effect of those medications on that. We've got a variety of different progesterone-only medications, which we can use for patients who have contraindications to estrogen to at least provide them with endometrial protection to prevent endometrial hyperplasia. And also in some forms can help provide contraception, but they're not going to help with the acne and the hirsutism. These are not going to be really helpful for regulating the cycle. And some of them, particularly the medroxyprogesterone acetate injections, of Depo-Shot is the brand name of that, can have a risk of weight gain. And so if we have a patient who's already struggling with weight, and we compound that by adding another medication that's going to contribute to their weight gain, that can be a real struggle. So this is not considered first line. This would be, kind of in specific situations if we are not able to take other medications. Again, metformin, really helpful for the insulin side of things. And so can kind of really help with improvement in their glucose tolerance, and help with some of the components of the metabolic syndrome. It can help restore some ovulation. So in some patients, they can get a little bit improved ovulation rates, but it's not going to be as effective as the hormonal therapies for regulating their cycle. So if the biggest concern for the patient is the timing of their menses, metformin is not like a first line option for regulating periods. So it's kind of like it has a little bit of a benefit for that, but it's not nearly as effective as like your combined hormonal methods. It doesn't have any anti-androgenic effects, so it's not going to help with their acne or their hirsutism either, and it doesn't offer any endometrial protection. And so we want to make sure that we're keeping those things in mind. It's also not a contraceptive, obviously, so for our patients that need some sort of pregnancy prevention on board, also always keep that in mind as well. But definitely, like if you have a patient who's been doing some lifestyle modifications, they've been on birth control pills and they're not like really kind of where they want to be, we might be able to add metformin as an adjunct therapy as well. Hirsutism. So again, that kind of unwanted hair growth, from a medication standpoint, again, our estrogen containing medications are going to be our first line therapy. We've got some other options. We've got some anti-androgen medications. Spironolactone is the most common that we use for this. The big thing to remember about these, and I'll talk about this on the next page too, but these have pretty high risk for teratogenicity. So if patient is taking this, it's really important that they also be on some sort of birth control at the same time. We've also got a topical medication, the eflornithine, which you can use in combination with like laser therapy to kind of decrease the appearance of the hair. There's all different kinds of hair removal techniques as well. Again, in general, you would try your estrogen-based medication first for about 6 months. And then if you're not getting, kind of the results that you want by that point, then you can potentially like add an anti-androgen like spironolactone on top for additional anti-androgenic effect. Again, spironolactone, kind of your adjunct medication if your estrogen-containing therapy isn't working as well as you want. You can kind of start low and kind of slowly work your way up. There's all this kind of like, in the past, people used to like do all these like routine, like screening, BMPs and all this kind of stuff, which is not really needed. So you can do kind of like a one-time check to make sure their kidneys work fine. And then otherwise you can just kind of prescribe as normal. It's not really studied in adolescents, so all the data we have is just extrapolated from how it works in adults. But the most important, the biggest thing is that they must be on birth control if they're going to take a teratogenic medication. This is the same for some of the other dermatologic medications that are out there. Like you hear about like people on Accutane, that is also a very highly teratogenic medication. And so making sure that we've got them on some sort of combination of birth control plus this. Again, so from an FDA approval standpoint, the topical medication is FDA approved for treatment of hirsutism. The birth control pills that contain certain progestins are FDA approved for acne. Keep in mind that all of them, regardless of the progestin that they have in them, are all going to help treat acne. These are just the ones that like actually went through the process of getting FDA approval for it as well. So that's out there. And then for whatever reason, the depot shot is FDA approved for control of menstrual irregularity, but everything else is off-label technically. So, which is how I think a lot of things, unfortunately, in the period world are. So kind of in conclusion, diagnosis of PCOS in teens, challenging, but early identification, very important, because then we have the ability to intervene and have good impact on some of their long-term health. Knowing that we've got this kind of category of at risk for PCOS that we can use to treat and intervene without kind of giving them the label if we're not 100% sure about the diagnosis yet. Being able to counsel adolescents regarding their future health risks can help mitigate some of these long-term effects. And then management of PCOS is lifelong and multimodal. So, right, this isn't something that is just going to magically go away in a couple of years or after taking pills for 3 months. So making sure they understand. And I talk to patients all the time. I'm like, this is like having thyroid disease. This is like having diabetes. This is a thing that we're going to be working on. I have things that we can use to manage the symptoms, but I don't have a cure, right? So this is going to be a lifelong thing for us. So some of my references here. Again, let's see, the ones to kind of point out here. So this one right here from Teed et al. Is that 2018 guideline that came out. That again is just like pages and pages of charts of very specific information on like exactly what lab tests to order and like exactly what kind of ultrasound probe to use at like what hurts and all this kind of stuff. So if you really wanted to get into nitty-gritty details, that's a great paper. And some of these papers down at the bottom are a couple of the updates from that guideline, kind of synthesizing it into more digestible information. So simpler to read charts, focusing, there's some that are specifically just looking at the guidelines related to adolescents and things like that. So those are some good papers to look at if you want to kind of have a refresh. All right, I will take any questions.
Thank you, Dr. Moon.
Let's see here. Let me get
Let me see. Yeah, we'll try and get the
chat box kind of.
Yeah, it may have disappeared on us. And let me go.
Oh, here, and I can do. I clicked the thing.
Yeah, there we go. We'll come over here. Let me look here just a second. All right, hang on. It's gotta go back this way. Here we go.
It's like, is it at the top or the bottom?
It's at the bottom. So
Okay.
most treatment for girls with PCOS, elevated testosterone and secondary amenorrhea, but no significant acne or hirsutism. Metformin alone if periods return on treatment, or prevent withdrawal after 3 months.
I would say in that situation, so if they have amenorrhea and elevated, like just like laboratory elevated testosterone, I still first line treatment would give them birth control pills or something that has that combination of estrogen, progesterone. So again, if they want the patch versus the vaginal ring instead, because that is going to regulate their cycle. That is going to help bring those testosterone levels down because maybe they don't have the acne and the hirsutism yet, but they're definitely at risk for starting to develop that because their testosterone levels are already elevated. It's also going to help with protecting their endometrium. So that's usually what I would go with. It's a lot easier too when we're talking about teenagers. If you're doing this kind of Provera withdrawal, I don't know how many of you guys have like prescribed that to teenagers, but telling them, okay, take this pill for like 10 days this month, and then like do it again this next, month or two. And like, they're just like, oh, I completely forgot about that after like 2 weeks. And then I just never did it again. So giving them something consistent that they just have to like keep up with is actually a lot easier than telling them to do this kind of like 10-day thing every once in a while. They just goes out the window. So yeah, I'd still do, one of the combined hormonal methods for that. Yes, there's a question in the back.
Coming back there, Dr. Dosser.
Thank you. That was a wonderful talk. 2 questions. One, I recently had a patient with MTHFR mutation who came in with irregular cycles and heavy bleeding. And from my little understanding of that mutation and the genetic condition, both progesterone and estrogen are kind of contraindicated or not indicated. How would you treat that? The second question, almost total ignorant about the fact of the teratogenicity of the spironolactone. Treatment for transgender male to female, does that affect the sperms and the teratogenicity as well, or is it only in females that it is teratogenic?
That's a good question. Okay, so this is where, again, admittedly, I'm a gynecologist, so forgive me a little bit here. I don't believe it's the same for male patients, right? Because from a teratogenicity standpoint, what we're talking about is somebody who is taking the medication and is currently pregnant. And so now their baby is being exposed to anti-androgen medication. And so that can have pretty significant impact on the development of the fetus. So it doesn't really like matter like what a guy is taking. It's like all about the in utero environment during an actual like developing pregnancy. And so that's kind of what we're talking about there. Because again, you start messing up the hormone situation while babies are developing, that can have pretty significant impacts. So that's that. Back to your first question. So this is getting a little bit away from kind of the PCOS side of things and more to like kind of talking about like clotting disorders and that sort of thing. So progesterone, just like very briefly, progesterone medications are safe to use in patients that have clotting disorders. So even if they have like a personal history of a clot, they actively have a clot, all of those different kinds of things, like progesterone hormones are safe and do not increase their clot risk. There is that like FDA label, and that has a lot to do with just kind of the impact of like a lot of things I don't have time to get into right now, but just like at baseline, progesterone only methods are going to be safe to use. Now with the MTHFR gene, again, kind of a little bit outside of the scope of this, but in general, it doesn't have the same clot risk that some of the other like inherited thrombophilias have. And so kind of depend, like, I mean, it kind of depends on the situation, but a lot of patients, I'll just counsel them and I may still go ahead and prescribe them something if it's indicated. So yeah. Oh, yes.
On the progesterone only medication.
Yes.
Do you ever screen for bone disease first, maybe with the DEXA or anything in general? And then also, how long do you feel comfortable using those medications before they might backfire on bone health?
That's a great question. So for those of you who didn't hear, the first part of that was a question about progesterone only medications and bone health. So in general, the one that is mostly implicated from a bone density standpoint is going to be, again, the depot shot. So that's the brand name, but like generic, the medroxyprogesterone acetate injection. I don't know from a CME standpoint, like how much I'm okay to say like brand names, but it's a lot easier to say just depot shot. And that one definitely, again, we have that black box warning about impact on bone density. And in general, that is considered to be kind of like after that 2-year mark of consistent use of the depot shot, right? But at the same time, we don't actually know the clinical significance of that. We know that it happens. But at this point in time, they've actually done away with a recommendation for any kind of DEXA screening for patients that are on it. So there's no like need to screen them before, there's no need to screen them during, there's no need to screen them after. So you just like don't even have to worry about it, basically. That being said, for my patients that I'm prescribing the depot shot to, if they are using it long-term, once we're hitting that 2-year mark. So I talked to them about that at the beginning, you know, that this can have an impact on lowering your bone density, but at this point in time, we don't know the clinical significance of that. It doesn't like increase the risk for fracture, doesn't increase the risk for osteoporosis that we know. We just know that like if I do a DEXA scan on you and compare you to somebody who's not on depot, that's your same age and weight and clinical characteristics, your bone density is going to be lower. It's also reversible. So when I take you off of it, your bone density rebounds, but I don't know long-term what the impact of that is because we just don't have data about it. And then once we hit that 2-year mark, I kind of revisit that like topic. And the clinical guidance that we have right now is that if the depot shot is the best treatment for the patient, and there's not another treatment that is preferable to them, then they can continue on it as long as they need. Right. Now, certainly I have some patients that have other risk factors for decreased bone density. And so in those patients, I may do some additional counseling about, you know, what might be the compounding effect here. But and like otherwise, like normal, you know, patients that don't have any other risk factors for poor, you know, for bone density, it's not as much of a concern, I think, as it was at the beginning. So
thank you very much, Dr. Ming. We're
Yeah.
going to